I would like to thank the organizing committee for giving me the opportunity to present this data on behalf of the ACTG A5260s study. HIV infection is characterized by a chronic state of systemic inflammation and immune activation that may contribute to end organ disease and may persist despite effective antiretroviral therapy. However, the differential effect of newer antiretroviral therapies, such as integrase inhibitors, on systemic inflammation and immune activation has not been well described. Plasma biomarkers have been used as tools to study systemic inflammation and immune activation. This is because they may predict mortality at end organ disease. More specifically, biomarkers of systemic inflammation, such as C-reactive protein and IL-6, and biomarkers of macrophage activation, such as soluble CD14, may predict mortality. In addition, biomarkers of macrophage activation, such as soluble CD14 and soluble CD163, may predict end organ disease, such as cardiovascular disease. However, it is unclear whether newer antiretroviral therapies, such as integrase inhibitors, and more specifically, raltegravir, may reduce systemic inflammation and immune activation compared to other antiretroviral therapies. Prior studies have shown that raltegravir may have increased penetration into the gut and may also have favorable effects on lipids compared to other antiretrovirals, such as protease inhibitors. In addition, very limited data suggest that raltegravir may also have increased penetration into other tissues, except for the gut, and this may contribute to increased local control of viral replication and inflammation. These tissue effects may contribute to reduced microbial translocation, immune activation, and inflammation. In addition, the favorable lipid effects, based on data in HIV uninfected subjects, and these effects remain theoretical and remain further to be studied in HIV-infected patients, reduced formation of inflammatory lipids and reduced hepatic inflammation and steatosis may also contribute to reduced microbial translocation, immune activation, and inflammation. Overall, the data regarding the effects of integrase inhibitors, such as raltegravir, on systemic inflammation and immune activation remain controversial. In view of these studies and the limited data regarding the differential effects of newer antiretroviral therapies, such as raltegravir, and new protease inhibitors, such as darunavir, our study aim was to explore how biomarkers of systemic inflammation and immune activation behave after initial therapy with tenofovir FTC backbone plus atazanavir ritonavir or raltegravir or darunavir ritonavir. In the next few slides, I'm going to use different colors to show data from these different treatment groups. Blue for the atazanavir ritonavir, green for raltegravir, and red for darunavir ritonavir. Our hypothesis was that the raltegravir-based treatment group would be associated with reduced systemic inflammation and macrophage activation compared to the other PI-based regimens. Our ACTG A5260 study was a sub-study of a parent ACTG A5257 study, which was a phase 3 prospective, multi-center, randomized, open-label trial of HIV-infected subjects, 1,809, who were ART naive. They were adults, and they had a viral load of more than 1,000 copies per ml. So they were randomized 1:1:1 to 3 NNRTI-sparing ART regimens. All of them had no known cardiovascular disease, no diabetes, and no use of lipid-lowering medications. All those subjects were followed over 96 weeks, and all of them, they received a backbone of tenofovir FTC. Then they were randomized to receive either atazanavir ritonavir, or raltegravir, or darunavir ritonavir. Our biomarker analysis specifically included patients who had suppressed viremia by week 24 and thereafter, and they had no ART interruption more than 7 days. And these are the final numbers per group, as you see in different colors. Our biomarker analysis included biomarkers who have previously been shown to predict mortality and end organ disease. More specifically, we measured biomarkers of systemic inflammation and coagulation, such as CRP IL-6 D dimer, biomarkers of macrophage activation, such as plasma-soluble CD14 and plasma-soluble CD163, and also pro-inflammatory monocytes, defined as monocytes who were positive for both CD14 and CD16. Those pro-inflammatory monocytes have previously been shown to be associated with cardiovascular disease in treated HIV infection. In addition, we measured biomarkers of T-cell activation, such as soluble IL-2 receptor and a percent of CD8 T cells, which were positive for HLA-DR and CD38, which are cellular markers of cell activation. So those biomarkers were measured at baseline prior to initiation of any therapy, at week 24 for cellular biomarkers, at week 48 for plasma biomarkers, and all biomarkers were determined at week 96. Then these measures were expressed as ratio of follow-up measures relative to baseline, so a relative mean fold change. A ratio of 1 indicated no change. So then we did pairwise comparison using the Wilcoxon rank sum test, and we adjusted for multiple comparisons. Our results, our study population included 90% males, adults with a mean age of 38. Less than half were white. They had a median CD4 count of 338 and a median log viral load of 4.6. Overall, there were no differences among the three treatment groups in terms of those baseline characteristics. In terms of systemic inflammation and biomarkers, first of all, we determined CRP. CRP declined significantly over time at week 48 and at week 96 in the atazanavir-ritonavir group, and also in the raltegravir group at week 96. In addition, when looking at pair differences among treatment groups, the reduction in the raltegravir group was more significant compared to the darunavir-ritonavir, which had a trend actually for increase at week 96 compared to baseline. IL-6 also significantly reduced over time at week 48 in the atazanavir-ritonavir group, but not in at week 96. Also, it significantly reduced over time at week 96 in the raltegravir group. In terms of coagulation, D-dimer significantly reduced over time at week 48 and at week 96 in both the atazanavir-ritonavir group and in the darunavir-ritonavir group. In addition, when looking at differences between groups, the reduction in the atazanavir-ritonavir group was more prominent compared to the raltegravir group. With regards to biomarkers of macrophage activation, soluble CD163 declined similarly across groups. More specifically, soluble CD163 declined at 48 weeks and 96 weeks, consistently and similarly in all three different treatment groups, as you can see here in this plot as well. However, soluble CD14 did not decline among all groups. These data are not shown here. So there was a major difference how soluble CD14 and soluble CD163 behave, although they are both considered biomarkers of macrophage activation. In addition, pro-inflammatory monocytes decreased significantly in the atazanavir-ritonavir group at week 48 and at week 96, and also in the darunavir-ritonavir group at week 96. In terms of T-cell activation, biomarkers of cellular activation, such as CD8 T cells, which were positive for CD38 and HLA-DR, they declined similarly across all treatment groups over time, both at 48 weeks and at 96 weeks. And those reductions were very consistent and very similar among all treatment groups. In addition, similar data were observed with the soluble biomarker of T-cell activation, soluble IL-2 receptor. Essentially, there were similar reductions over week 48 and week 96. They were similar in all treatment groups. These data are not shown. Our conclusions, The biomarkers changes varied by regimen. CRP declined with atazanavir, ritonavir, and raltegravir throughout 96 weeks. IL-6 declined with raltegravir, but not with atazanavir, ritonavir, and darunavir, ritonavir at 96 weeks. D-timer declined with atazanavir, ritonavir, and darunavir, ritonavir. After ERT initiation, T-cell activation, soluble CD163, but not soluble CD14, declined similarly across all groups. Over 96 weeks of follow-up, raltegravir doesn't have differential effect on systemic inflammation and immune activation compared to PIs, and these data are consistent with prior studies. In addition, we are also performing a further analysis of these biomarkers as predictors of end organ disease, such as bone disease and cardiovascular disease. These results suggest incomplete reversal of inflammation and immune activation in the setting of effective treatment with these different therapeutic agents. Longer follow-up may better define regimen difference and correlation between these measures and long-term complications. I'd like to thank my mentor, Dr. Judith Courier, and the rest of the ACTG A5260 members, all our ACTG sites, our patients, and our sponsors. And I'll be happy to answer your questions.